Uh, uh, Good morning, everybody, and we are going to talk about MASLD and role of dual PPAR agonist. Fortunately, I have been able to remove few of the slides so that they do not overlap with Dr. N.K. Singh, as suggested by Dr. Bansi. This is the best slide that I could post for the history of diabetes, and I went through that museum yesterday, and it is really worth visiting if you are not visited online. We all know that NAFLD is now a revised name nomenclature. It is no more known as NAFLD, but is known as MASLD because of lots of metabolic association. The definition remains same. Those trials which have been carried out on NAFLD, the data would remain the same. So that data would also apply to MASLD, and the definition stays as it is. More than 5% fat plus any of these parameters would lead to the definition of MASLD. And under the head of MASLD, there are lots of different categories which is worth visiting. What we are going to do is have a look at MASLD for first 5, 6, 7 minutes, and then the management. So MASLD could have alcohol less than 30 grams, could have alcohol more than 30 grams, could have lean patients, could have obese patients, and depending upon that, the definition or the ultimate, the classification would change. Again, MASLD and MAFLD are two different categories. The MAFLD is determined by negative impact, while the MASLD is determined with positive and negative impact both. One looks more at the glucose metabolism, the other looks more at the obesity or the fat metabolism. The epidemiology, we know it is one of the most common cause of chronic liver disease in the world. 4 to 10 times higher incidence of metabolic syndrome. 20 to 25% of MASLD patients ultimately develop MASH, that is steatohepatitis, and about 6% of patients develop cirrhosis. So now, before we move ahead, just look at the thing. We are having two things. A patient has metabolic disease, who can develop liver disease, fibrosis, cirrhosis. A patient having fatty liver can develop metabolic disease. So now we are creating a link between metabolic disease and gastroenterology, and that is what the importance of MASLD is. It's more common in males than females. Obviously, it is associated with or completely correlated with insulin resistance, and it is considered to be the root cause, and that's why from NAFLD we moved on to metabolic disease, because insulin resistance is the root cause. Lots of pathological associations starting from stroke to coronary artery disease to atherosclerotic heart disease. Most importantly, recently multiple studies have come which suggest its association with CKD. And there are now lots of trials which suggest that if you have got fatty liver, keep an eye on renal function, because these are the patients who are more likely to go for CKD, non-diabetic CKD. If the patient does not have diabetes, the conversion of NAFLD to the liver transplant, that timeline is little prolonged. Just have a look, NAFLD to NASH conversion is just 10 to 20%. But the moment the patient has a metabolic disease associated with NAFLD, the conversion from NAFLD to NASH is practically doubled. And look at the chances of hepatocellular carcinoma. It's very high. And that's why every patient having metabolic disease has to be looked for or screened for liver disease, and every patient having liver disease has to be screened for metabolic disease. The slide nicely shown by Dr. N.K. Singh, and it once again brings you the importance of FIB-4 score before going for anything else in a patient having metabolic disease. Why? Not only the FIB-4 score is easy to perform, but now again there are lots of trials which suggest that FIB-4 score in a patient having metabolic disease. When we say metabolic disease, it could be obesity, it could be diabetes, it could be insulin resistance syndrome. In a patient having metabolic syndrome, FIB-4 investigation or the results of FIB-4 are directly related to CV disease, all-cause mortality and liver events. So a simple FIB-4 can predict lots of complication. How do we manage? Whenever we are managing NAFLD, we have to look for three things: control of pre-diabetes or diabetes if it is there, then control of obesity or other metabolic factors, and also to look for the deterioration of liver condition itself. And depending upon that, we have to control or prevent cardiovascular disease, and we have to prevent the deterioration into cirrhosis. How can we do it? Lifestyle modification, comorbid conditions, pharmacotherapy and bariatric surgery. So let's jump on to pharmacotherapy because that is the important thing. 4 years back we had very limited things to know about this entity, and now the next 3 slides or 4 slides are probably going to give you the agenda of next or the very next CaReMeLO symposiums, because now there are lots of ways by which you can attack the MASLD, either by attacking the inflammation or by attacking the adipose tissue or by attacking the targeting the liver. So there are different ways, and by that there are different modes of drugs. This is the timeline by which the drugs were developed, and now look at what is happening. So many trials are going on. In fact, MASLD, diabetes and chronic liver disease have become the center stage of most of the studies. And these are the newer approaches, and probably next 5 years we are going to talk on these drugs only. The newer approaches target different receptors, and these receptors are not only going to control the CLD, they are also going to control the metabolic disease. These are the clinical studies that are going on, out of which we at present only know about tirzepatide, but there are so many drugs that are in the pipeline. So now we go to the second part of our story, and that is role of dual PPAR agonist. So most of us have heard the word, but we hardly know what is PPAR receptors. So they are peroxisome proliferated activated receptors, PPAR, which are ligand activated nuclear receptors which work on liver, adipose tissue and also on pancreas. There are 3 PPAR isoforms: PPAR alpha, PPAR gamma and PPAR delta. How do they work? PPAR alpha are known to us through fibrates, PPAR gamma are known to us through thiazolidins, and PPAR dual agonist are available as glitazars that we'll have a look at it in next few minutes. There are PPAR delta receptors which are now being targeted for obesity control, and then there are PPAR pan agonists which are jumping to enter into our pharmacotherapy very soon. How do they work? PPAR alpha agonists work mainly on liver, PPAR gamma receptors mainly work on adipose tissue. One take care of the triglycerides, the other take care of the glucose metabolism, and that's how they differ in their effect. So whenever you are using a dual receptor, they would work both like fibrates and control triglycerides, and will also work like glitazone and would control glucose. There were 2 dual PPAR gamma and alpha receptors were available, but because of side effects, both could not take the center stage, and ultimately they were withdrawn. So now we have got only one dual PPAR agonist available, and fortunately that's an Indian make, the first Indian make, and that is saroglitazar, which is also known as good glitazar. It is probably going to take a center stage for next couple of years. Why I am saying couple of years? Because after that we might have a broader spectrum agonist. So what does the drug do? It affects the atherogenic dyslipidemia, and it also acts on the non-alcoholic fatty liver. So it targets both the things, metabolism and also the liver, and that's how it's now approved for MASLD. Lots of trials. In fact, I was a part of saroglitazar study initially when it was launched, but later on, for last 3 years, they've come out with lots of trial targeting MASLD and with excellent results. Most of the trials are from India because in US it is undergoing phase 2 study at present, but from India there are lots of trial. Indian data is there which suggests that it is effective on biopsy-proven NASH. MRI study which has been done with the help of fibroscan, you can see as compared to placebo, it shows the reversal, for the first time it shows the reversal of fibrosis and steatosis, and then one can see the wonderful safety of the drug. We all have used the drug, so I'm not going into the detail, but then came the lead EMR1 study which again showed the efficacy of seroglitazar in control of triglycerides, in control of liver fibrosis, and also in reduction of HbA1c. As you can see, the reduction was by 0.69 to 0.72%. At various levels of HbA1c, the drug affects the metabolic MASLD, and it's absolutely safe, no relation with renal problems. And that's why the three important guidelines are now suggesting to use this drug, LAI, RSSDI 2022 and INSL. And what INSL has done is, it is put seroglitazar even before PPAR and vitamin E, because PPAR and vitamin E, as you know, they are off-label drugs. So seroglitazar now occupies a center stage as far as MASLD or NFLD is concerned. Don't forget the lenifibranol, which would be there within a couple of years, and it is a pan-PPAR agonist, which means it affects all three PPAR receptors, and a native trial has recently come out showing excellent results with it, but the drug would take a couple of years before it comes. Of course, we should not forget the resmetirom, which is not a PPAR gamma receptor agonist, but it has been FDA approved. Important thing is now all the institutions suggest three important things. Patient having diabetes must undergo FIB-4 score. Patient having fatty liver must undergo metabolic evaluation, and that is what is very important. So simplifying the approach, if the patient has metabolic disease, screen and work up for NAFLD or MASLD so that you can prevent the liver fibrosis in future. If the patient has fatty liver, just investigate or work up for metabolic disease, especially type 2 diabetes. Keep our lifestyle changes on. So concluding this topic, MASLD is metabolic dysfunction associated steatoliver disease. There is association of at least one cardiometabolic factor is a must out of these 5. The screening is very, very important, especially the FIB-4 score in diabetic patients. Lifestyle modification is very important, and seroglitazar is at present occupying the center stage. So what's the message? Once again, I would like to draw your attention. ADA, RSSDA now advises universal screening of people with type 2 diabetes and pre-diabetes for fatty liver disease, and that too with the help of FIB-4 score. So if our diabetic patient has not undergone FIB-4 score, it is not an evidence-based therapy. That is what is going to occupy the agenda of next RSSDI or probably DiaObecon conferences. So 2017 we used to talk about liver this way, but now in 2025 or 2030 the talk would be different. It would be solely dependent upon MASH. So that's where I will stop. Thank you.